Medicity is sponsoring this lunch meal. So when you get a chance, talk to Brad. I think Brad is actually putting it right on his credit card. So Medicity, for those of you who don't know, is our statewide HIE vendor. We have already selected them via an RFP process, so Brad, the meal really won't sway us anymore. It's been good to work with Medicity through the last year and a half. They've certainly brought all the things to the table that the Health Information Exchange needs, not only in South Dakota, but a long ways beyond that. So I was telling some people in the previous session, Tim, that if you look at it as a skip level, I work for you. So Kimberly Lynch is ultimately my boss. She's the director of the Regional Extension Center program for ONC. She comes to us this morning from Washington, D.C. Hopefully you haven't had too much problems with Sandy.
No, not slightest.
Okay, good. Kim has really been a high-quality individual that's been tapped not only at the national level by the Office of the National Coordinator, but in Michigan. She was the original, she's the one who stood up Michigan's Regional Extension Center program, and in fact prior to that, she served as on Governor Granholm's administration as an HHS policy advisor. She's got a real strong background in public health, mental health, long-term care, and women's agenda items. She's worked in a number of capacities: governmental affairs in Blue Cross, Blue Shield of Michigan. Ms. Lynch has a master's in public health from the University of Michigan and a bachelor's from Michigan State. So she's been a Midwestern girl. I can tell you that she just recently come back off maternity leave. So congratulations.
Thank you very much.
And I will turn it over to her. Let's give her a South Dakota welcome.
Thank you, Dan, and thank you, Holly and Jeff as well from the Health Point team. I'm thrilled to be here today, and thank you so much for that kind introduction, Dan. But if I had to describe our relationship, we are partners, as ONC is with all of our RECs and all of our funded organizations across the country and our many stakeholders. We are partners in the work we are doing to help providers get to meaningful use, and we really try to live that in every way we can. As the federal government, we try to have a very light hand in what we do in funding these activities. We really want the tapestry of programs that we've supported to help providers be exactly what's needed in every market across the country. And we know that what is needed in Michigan is not necessarily what's needed in South Dakota, which is not necessarily what's needed in California. And we have really enjoyed, I certainly enjoyed working at ONC for the last year and a half, working with this amazing tapestry of regional extension centers and all of our other partner programs, the HIE program and so forth. So I'll get into that a bit more in a minute. But so Dan introduced me as the director of the Regional Extension Center program, which is true. But so you know where I and the REC program fits in the broader scope. The REC program, Regional Extension Center program, is in the Office of Provider Adoption and Support at ONC, an office that we lovingly refer to as OPAS, because we have a lot of energy in our program. We are where the Health IT Workforce program also resides, but we are just down the hallway from the state HIE program and the Beacon Community program as well. And then all of that is consolidated within the Office of the National Coordinator for Health IT, and that person right now, I hope you all know, is Farzad Mostashari. And Farzad reports directly to Secretary Kathleen Sebelius. So there are three things that I want to cover today. One, I want to give an update on where South Dakota is leading the nation in supporting providers in getting to meaningful use, but also identify some real concrete opportunities for South Dakota in the future to accelerate that effort, specifically through the lens of rural providers. We at ONC have been doing a lot of work since the grant programs were announced back in 2009 around rural providers, but we've re-upped that in this year's policy agenda to set some concrete objectives on critical access in rural hospitals and getting those hospitals to meaningful use. So so I'll talk a bit more about that. And finally, how meaningful use is truly just the beginning of the transformation that we are hoping to effect. So we've got my next slide up. And really what I want to start with is meaningful use in common terms. I think everyone in the room has got a good basis on what meaningful use is and what it isn't, but maybe some of this shorthand is helpful to you as you're still out making the case for why meaningful use. How is this not just another government check-off program and the ending, you get your check and you walk away? Well, meaningful use stage 1 is about having a certified EHR that you use in a meaningful manner. So that means electronic prescribing and quality reporting and able to exchange health information. Not necessarily doing that exchange yet, but able to do health exchange. Meaningful use over time, though, is really what we're getting at. I like to describe the RAC work as terribly unsexy work. We talk about it all the time. This is not sexy stuff. We are building roads. Building roads is not sexy. But building roads is what allows you to do everything else that we do, right? From fun things like going to the store, going out on movie dates, getting hauls of goods and services all over the country. Roads are critical infrastructure. That's exactly how we consider the RAC program. The RAC program is critical infrastructure to allow for things that we haven't even dreamed of. And so this slide gives you just a quick glimpse into that transformation as we see it right now. We see meaningful use and health IT adoption being the basis upon which you can do patient care coordination. Real patient care coordination that involves the patient. As I know you heard Regina speak earlier today, we mean it when we say the patient must be part of that. And in order to have the patient be empowered, be engaged, they have to have access. We completely agree, and it's how we built Meaningful Use Stage 2. We are so excited about Meaningful Use Stage 2 because of the real and true engagement of patients that it begins. Again, none of this is an end. It is the beginning of a transformation. Next up, looking at data continuity and team-based care. We want any provider who's touching a patient to be able to communicate. We want your primary care provider, any specialist, any emergency visits to be able to communicate. I think we all agree that that's the outcome that we're getting towards, but we have to build the roads first. So at their simplest, meaningful use over time will achieve all of these things, but it also enables payment reform. And I think that's one other thing that most of us that have been working in the healthcare industry for a long time can really appreciate, that in order to transform our healthcare system, we have to transform how we pay for healthcare. And that means transforming from a fee-for-service model to a model that pays for health. And the IT that we're talking about, the adoption that we're affecting right now, enables that payment. It enables the population management of your diabetes patients, of your cardiovascular disease patients in ways that you've never been able to do before at a quick glance. And it empowers providers to be able to make more effective decisions within their practices, and patients, again, to be active participants in their health. Next slide. So again, there it is. So taking that goal, that vision that we have for meaningful use, and understanding where the Regional Extension Center and the HIE program and even the CMS incentive programs fit in. This is the framework for the High-Tech Act that was passed in 2009. And up at the top you see the Regional Extension Centers and the workforce training. Those two programs, as I said, are in the Office of Provider Adoption and Support, and combined, we are facilitating the adoption of EHRs, the roads. Then you see the Medicare and Medicaid incentive programs, and of course the penalties. That, of course, incentivizes providers to make this transition, because we have the zealots, we've had the zealots, we had the folks that were easy to move, and now we've got to move the folks that are not as easy to get across the finish line, and the incentive dollars can certainly help make the case for those providers. Then down at the bottom you see the Grants for Health Information Exchange, Standards and Certification Framework, and Privacy and Security Framework. And that really enables the Health Information Exchange. So while the EHRs have the requirement to be able to exchange, there's a whole lot more than the technology, as I'm sure we all know. A lot more than the technology has to be in place to enable exchange. And together, all of these things come together in meaningful use to improve individual and population health outcomes, increase transparency, and improve our ability to study and understand care delivery patterns. So just by the numbers, we have 62 RECs, as I mentioned. We have 56 state HIE programs. There are 17 Beacon programs. There are 4 SHARP research projects that you may have heard of, standards and certification specifications, and teams working there with the new Health Information Network. Workforce training programs, our 2 federal advisory committees, and not the least of which is our certified vendor list, which as of April had 764 vendors and developers, and over 2,000 certified vendors. So really, this is, from ONC's perspective, the network of people that we tap into to help make this change happen. And this is obviously just the top level, because there are people like you in rooms across the country that are working and doing the hard work of this change every day. So next slide. So the framework for the Regional Extension Center program is really a plan, do, study model of planning, transitioning, implementing, operating and maintaining, and improving care quality. This is the cycle that every REC across the country works with their providers, and sometimes this cycle gets repeated multiple times in order to affect adoption. If you've ever tried to implement an EHR system or any type of IT in a healthcare practice, my background is doing it in critical access hospitals and in rural practices, you sometimes have to do this several times. It is not one day, one meeting, everybody's on board, and you're just installing and turning on a light switch. I think, again, everyone in this room knows this because you've lived it. But what's key about this process is that you can replicate it for almost any small transformation or large transformation. And RECs act as the coach, as the catalyst, as the external force to support a practice making these changes. It's hard, but it's a whole lot easier when you've got a buddy who can talk you through it, who can say, you know what, I understand that this is difficult, but here's another provider that looks like you, another pediatrician with your same kind of patient mix, and where they found this to be really effective. Here's another internal med doc, just like you. Let's give them a call. They installed NextGen last month and already worked through some of these kinks. That catalyst, that coaching role of the RECs, we took a bet in the HITECH Act that would be an invaluable resource, and we have heard over and over and over again across the country from providers saying, I never would have been able to do this. This would have been so much more painful, and I would have given up if I didn't have the help of the regional extension centers, the help of that coach to come in and say, it's going to get better, it's going to get easier, and let's flip that switch, let's see what happens, let's just turn this thing on and start working through the kinks. So who RECs are helping? And this next slide, thanks. This is just background information for folks, and by all means steal this information if it's useful to you and when you're out communicating in your networks. Right now, the RECs are working with over 130,000 primary care providers. That number jumps another 10,000 when we look at specialists. And this is the breakdown of who RECs are working with by practice type. But our focus is on primary care providers. The hardest of the hard primary care providers. We didn't set out to go with those folks that were neatly organized and we're probably going to get assistance from a hospital or health system. The REC program was designed to go after those independent small providers, rural providers, urban providers that don't have the kind of support networks in place that would allow them the time and the resources to effectively adopt IT. Next slide. So today, with the REC program up and running, and our goal initially was 100,000 providers, so we've exceeded that tremendously by over 30%. Over 40% of all primary care providers in the United States are working with a regional extension center. We were stunned by this number. We did not expect it to be this high. We expected it to be even harder to get that last 20,000, 10,000 into the program, but in fact we shot the moon and ended up with 130,000, and there are more being enrolled all the time. Providers keep on coming back to RECs and saying, look, I wasn't on board initially, but can you still help me? Because, okay, I understand, this is really going to happen now, or, we hired a new doctor who's saying, look, I can't work like this. I need electronic records. We need electronic records if we're going to survive. So RECs, these numbers keep on going up, the share that the RECs are working with. But I want to focus in on that 70% of all rural providers. Talk about a stunning day around the office. This number went back to our stats team, I think, 3 or 4 times. Really? 70%? Are you sure? Are you really? Before we put the secretary out talking about that number, are you sure? And it's true. Knock their socks off. That 74% of federally qualified health centers or community health centers, that's low. We just ran the numbers again last week, and it's 85%. Again, knocked our socks off. We knew that this was our key audience, it's who we were targeting, but to get these kind of numbers knocks our socks off. But it also creates an urgency around ONC and now we're going to do right by every one of those providers. And we put that urgency right back into our grantees. So Holly and Dan and Jeff certainly know it well, that we point out, these are awesome numbers. We are really getting it done. Can you actually go to the next slide? We are really getting it done. But for every single one of those numbers, that is a commitment made. That is a provider committing to meaningful use and to partnering with the REC, but that is a commitment right back to that provider that we will see you through. We will help you. When it's hard, when it's messy, it's great when it's easy. But when it's hard, we're not walking away. Next slide. So there we go. So as of today, I mentioned that 130,000, this again is primary care providers, and that just that priority cohort, that small group, primary care providers. As of today, we are 96,000 providers, so 96%, to our milestone 2 goal, which means live on the EHR. This is a stat that Farzad, that person I mentioned, the national coordinator, in a meeting last week, he said, Kim, wait a second, that's huge. We need to take a moment and celebrate what that means. And me being the glutton for punishment that I am, I said, yeah, I'm not buying it. It's great. I'm happy. But the RECs will never hear me talk about it. Because the big kahuna is meaningful use. So I am thrilled that we have 96,000 providers live on an EHR. But to me, that is only the beginning of the fierce momentum that needs to kick in to get all of those providers to meaningful use by 2014. Now, the 2014 deadline is the deadline for the REC program, but that's great because it obviously coincides with the incentive programs and the maximum dollars that can come in, and obviously getting in before the penalties also start up. But that 28,000, we expect it to be somewhere around 35,000 by the end of the year. So we'll cross the 28,000 mark this month. I'm waiting for the day. There's going to be a whole lot of yelling in our office when we cross the 30,000 mark. It's a big deal. But for us to get all 100,000 providers to meaningful use by 2014, when our program funding ends, that means we have to get over 4,000 providers a month next year. We've never done that yet. But we're going to. So looking at the next slide, this actually gives you some of our trend lines, and we are very data-driven. How many folks have heard the name Nate Silver recently? Anybody? All right, a few hands. All right, so Nate Silver has been the breakout nerd of the election cycle. And there's been a discussion of how Nate Silver is so data-driven, and there's proof that math works, regardless of your political affiliation. We cheered that at ONC because we too love math. We too love data. In fact, if it doesn't show up in one of our metrics, if someone tells me, don't worry, Kim, I'm going to hit my targets. No, it's all in the queue. And I say, that's great. Until I see it on paper, it didn't happen. Because until I see it on paper, it didn't happen for that provider. And that's the reality that we hold ourselves to. We don't celebrate a lot of those interim marks because it isn't the final goal. So these curves show, the blue lines give you what our enrollment trend was. And so when we had our big bell curve, the green line gives you our go live curve. And then that red down there at the bottom, providers that have the fewest resources. But that second point, there's a GAO report, and I can get the reference for folks, that said providers working with RACs were 2 times more likely to receive meaningful use dollars. So proof that that coaching, that assistance, that outside, we're going to get it done, really makes a difference. So let's look at South Dakota for a minute. So this slide, and my slides will be available if they aren't already, but this slide gives you a lot of information, and I want to hone in on a couple of points. So on the left-hand side, you see registration, AIU, paid for meaningful use, and demonstrating meaningful use. So let me walk you through what those categories mean. So registration means providers registered for either the Medicaid or the Medicare Incentive Program, and the third set there, the not registered numbers at 481 and 55%, that to me is a huge opportunity. That means that there are 481 providers working with the South Dakota RAC that still haven't registered. AIU, that's that first Medicaid payment. 28% of those Medicaid providers that are registered have gotten paid. That's actually a pretty good proportion, but again, huge opportunity for getting those Medicaid providers registered and getting them their first payment. Because for Medicaid providers, it's over $22,000. That is a game changer in Medicaid practice, especially when you're multiplying that $22,000 by several heads, several eligible providers. Paid for meaningful use. Now this is just getting started for a lot of programs, but what's great is that you can look at the number of providers registered as a queue up for AIU and also for meaningful use. So this is how we look at data at ONC to see what does that pipeline look like. If you've got a big stack of people in AIU and so they're going to hit meaningful use in 2013, great. Let's talk about that. Let's break that down. The final grouping, demonstrating meaningful use. So we understood that with Medicaid programs and the meaningful use program that CMS launching at different times, we needed a way to again, understand the queue of providers that are getting ready, that are this close to getting that meaningful use payment. And so what we did with the RAC program is we mimicked CMS's system for attestation and built what we call an M3, a milestone 3 tool. That tool allows an RAC to run a provider through, so get the same report and run the provider through the meaningful use criteria. It's a great precursor to actually attesting. It's a know before you go to a test kind of tool. But again, that gives us a nice cue of where folks can go. Finally, you see the critical access hospital meaningful use. Now this is an interesting nuance to the RAC program. We put out a supplement of $30 million to specifically support critical access and rural hospitals. So that was on top of the funding that we provided for providers. We did a supplement to provide additional funds for RACs targeting and working with critical access in rural hospitals. So here in South Dakota, you all have funding for 48 hospitals. 13 of them are already demonstrating meaningful use. That does not mean that they've gotten meaningful use payment yet. Please, don't start making phone calls just yet to find out if you're in that list. But it means that providers at 13 critical access or rural hospitals here in South Dakota have demonstrated meaningful use, that they have either received a payment or that milestone 3 tool has said, you're green lit. All you need to do is go queue up and you will get paid. So that's tremendous. Having 27% of your critical access hospitals demonstrating meaningful use in some way, that's awesome. Another highlight is your registration proportion for Medicare, that 35%. That's green on here because that's top 10 in the nation. So South Dakota has some real strong points to keep building off of, but also, as you can see, a lot of opportunity here to make some incredible progress at the end of this year and running hard into 2013. Next slide. Since we're running short on time, I'm gonna hop over a couple of these. This is just a great FYI as you're communicating or want to go back and look about our stats, rural versus metropolitan, how the RAC program breaks down. The next slide, here we go, is specifically the locations of critical access and small rural hospitals working with an RAC. And again, this is something we are tremendously proud of at ONC and are really dedicating a lot of effort into working with our RECs that know these hospitals best. Because I am very quick to say on our team, I did implementations in critical access hospitals 5, 6, 7 years ago. They look nothing like what's going on today. We need to go to the experts in the field and find out what's going on, what's working, what's not working. And that's what these hospitals represent. These are our on-the-ground touch points to inform policy at ONC, where we spend our time and resources. But the RECs are our conduit to those hospitals. We're not going to call a critical access hospital and ask them, how's it going? But we turn to the RECs and say, help me understand, what's a specific barrier that's holding up a critical access or rural hospital? Or on the flip side, for the hospitals that are demonstrating meaningful use, what clicked there? Why were they able to cross the finish line? And then we cycle those findings back into the program. We have webinars all the time where experts that have been working with hospitals get on and say, look, this product, these hospitals, these barriers, here's how we solve it. And it's that kind of small group, tactical planning that really is showing dividends in our numbers. We are seeing the progress of, okay, we can get together. This vendor has gotten this hospital across the finish line. Let's figure out where else we can do that. But likewise, where we have issues, how many folks have Healthland as a system? Do we have any critical access hospital representatives in the room? Are folks familiar with Healthland? Oh, there we go with that. Thank you. All right, so Healthland is a big critical access hospital vendor. We went to their summit a couple of weeks ago and had a sit down with Healthland and said, guys, we've got to do better. There are commitments made to these providers. You've made commitments as a vendor. We've made commitments as the coaches for these practices. They need more help than they're getting. And Healthland turned around and said, we're in. Now, it's not solved yet, and we're certainly not going to claim victory on just that communication point, but it's an example of we're looking at our data, we're looking at who's getting across the finish line, who's having a hard time, and working diligently to try and solve those problems, to get the solutions back into the field. We're not going to let anybody slide. We're not going to claim success, at 70% of our goal. We mean it when we say 100,000 providers across the finish line. Speaking of that, next slide. We are systemically tracking barriers. I talked about this a minute ago, about looking at the barriers that providers are reporting. And this is just a quick glance into our rural provider lens and what they're reporting as their top 10 barriers. Now, you see number one is the meaningful use measures. Well, you obviously have to go into a lot more detail on that. Which measure is the problem? Why is it a problem? What vendor is the problem? Where is it presenting? Not, one rural provider is not like the next rural provider. So we do analysis at ONC to say, okay, which measures are a problem? Let's look at it by geography. Let's look at it by measure, by geography, by vendor type, by provider type, and figure out what's going on. Where are we seeing patterns? Where are we seeing successes, again, that we can look to and say, how did you solve this? We need to cycle that solution back into the field. And this repeats itself over and over and over again for each one of these categories. So I focus in on this because I feel like this is such a critical difference of how we do business as ONC, how the RECs do business, from your typical kind of government grant program. We are constantly striving to do better, and we mean it. And if anyone has feedback on how we can do it better, I'm going to hang out for a while after my talk, and I'd love to hear your feedback on how we can do this better, because this process was born out of feedback from the RECs saying, look, we're behind. The technical assistance that ONC is putting out is, maybe a few months behind where we need to be. We need more real-time information about what's holding providers up and having ONC focus in on that. And we said, you're absolutely right, let's build this, let's track it, and then this guides our work. This is what my team does. Moving on, the last section here. We're talking about how, with all of this infrastructure, all of these unsexy roads that we are laying down across the country, so what? So that first slide, talking about how meaningful use builds upon itself, and then builds us into transforming care. We see the RECs as a foundation level of trust in the practice. Again, those commitments that have been made to providers and providers back to the RECs, it's foundational. Those supporting services that we provide that can be replicated in lots of different ways, we're always trying to do that better. We know we can always do that better. And we're also looking for ways that that can be deployed for other programs. And RECs are doing it right now. There are RECs today that are using the service model of the REC program and meaningful use as a base to support that top level pyramid here, the three-part aim. How many people are familiar with the three-part aim concept? All right, okay. So the three-part aim is lower costs, better quality, and better health. That's what we're about. We're about improving those outcomes. Using the trust that we have with providers, whether you're an REC or anyone else who's interested in doing this work. The trust of providers, using a continuous improvement structure, a data-driven approach to how you do your work, using meaningful use as your base. That's when we start moving into these exciting new opportunities, medical homes, accountable care organizations, payment reform pilots that start getting under the bed covers of how can we really transform the way care is delivered in the country. So, next slide. We asked the RECs a year ago, and we're going to do this again soon. What are you working on right now to support three-part aim programs? And we asked it in a very broad lens because we wanted to capture the totality of where folks are being creative. You see, medical home, 98% of RECs that reported either doing that work or looking to do medical home work in their regions. Payer pay for performance, we have a ton of RECs that are partnered with payers in their states or regions, and many, many more that are starting those relationships to partner with a payer and say, look, if you will pay this to a practice, and you will help with the technology, if you will help with the staff time to achieve a medical home, we will come in as the REC and support that activity. We will be the coaches for that activity as well. Partnership for patients, care transitions, very similar in a lot of ways to PCMH, but targeted in different aspects. Accountable care organizations, as I said, innovation challenges, those are primarily being funded right now by CMMI, the CMS Innovation Center. Payment reform and other three-part aim programs. I expect these numbers to jump significantly in the next year when we ask the RECs again about this activity. But the RECs are obviously just one part of many, many folks in the healthcare system working on these activities, and we as ONC think that's fantastic. We want more activity, not less. Next slide, I'll skip over this one quickly. This is just a quick highlight of where work is being done, and South Dakota had told us last year about how they're working with HRSA-funded projects around PCMH promotion, and we were very happy to be able to highlight that to the Secretary. This is the kind of summary that we provide to the Secretary and tell her about the excellent work that's being done in every corner of the country, leveraging these roads that we've laid down. See, the next slide just gives another lens into primary care advancements that I've already touched on at most of the high level. And then finally, some detail on meaningful use and meaningful use. So we put a challenge out to the RECs this summer, asking how can you make meaningful use meaningful? How can you take these roads and really help folks understand the higher purpose? Yes, the ways that you can deploy this infrastructure in ways that truly affect patient care. And I've got profiles here of the North Carolina REC and in Louisiana the No AIDS Task Force. But these are just examples of how communities, not necessarily RECs, but how communities are coming together and saying, look, we're going to use this infrastructure in a way that makes a difference in our home, for our family, for our neighbors, for the patients we take care of. And that's the kind of activity we want to hear, again, in every corner of the country, and we want to support in any way that we can as ONC. So at this point, I will stop. I'm happy to take any questions if those have them, but I also know that there's, I think, a representative here from South Dakota Medicaid that may be coming up. So I will try and keep it brief. Questions? Yes, please. We certainly have some commonalities one meaningful use measure that we've seen a lot about. But what we've seen is that in many cases, providers are having no problem. And so what we did is we went back to those practices and hospitals where they have achieved meaningful use and said, okay, so how come the after-visit summary is not an issue here? And what we heard, by and large, was, look, folks didn't understand why they needed to do this. They didn't know how to put the after-visit summary into their clinical workflow. It was really disruptive. They didn't have a setup in place to print it off in a way that the patient could get it. It was, people were tripping over themselves. And then once they handed the information to the patient, the information was either not useful to the patient, it wasn't put in a way that the patient knew how to take any action, that it could scare people. There was a lot of fear around the after-visit summary. And so what ended up happening in those leading RACs and leading practices was breaking down the after-visit summary and starting with why. Why are we asking for this in meaningful use? So the answer on the after-visit summary was, well, this is a communication tool. So let's get some best practices together on why we're asking for the after-visit summary, how that empowers patients, how that improves care. Let's get some trainings out to the providers on those that have implemented these changes and did the hard work on their workflow and helped their providers understand why this was a valuable communication tool. Get that out to the provider community so that if you are helping a practice or if you're a practice going it alone, you can see another provider say, okay, I wasn't thrilled about this perhaps, but this is why I'm doing it and this is how I'm doing it. We also put out tools on the workflow side of it, where an after-visit summary can be produced in the workflow and how to make it useful and meaningful in the communication back and forth between the patient and the provider. So that's one measure that we've heard a lot about and we've in turn put a lot of resources into, but I will say that those resources are also continuously being refined. So as soon as we put them out internally to the RBC program and launching them publicly through healthit.gov, we're also asking for provider feedback on how we can make them more specific. So we're hearing, could you do a module of this just for pediatricians? How can I make an after-visit summary useful for, obviously not necessarily my pediatric patients, but for their parents? And so that's the kind of nuancing. Once we identify a challenge, we are honing in on the solutions that can help make that better and looking back to the community to help provide it. And then how do we refine those tools in specific provider segments for particular vendors to help make it stick. Does that help? Other questions? Yes.
I know incentives aren't everything, but they're helpful. And rural health clinics and provider-based clinics, those providers are kind of left out of this whole picture of incentives.
So that has been an issue and one that has caused a lot of heartache in I think every rural health clinic, and certainly for us at ONC and at CMS. I think it's been fairly well communicated that that was an unfortunate legislative error that was made when the HITECH Act was passed, and it therefore required a legislative fix. If we could have done it through policy, if we could have fixed that through policy in any way to make the rural health care providers eligible, we would have done it. But it would have required congressional action. And that's the honest truth of how it went down. And so for an REC perspective, the only little slice of this that I can actively control, we said, we don't care if they're eligible for incentives or not, RECs can help RHCs. So it's not incentive dollars, but the RECs could absolutely benefit from the REC subsidized help.
Do you see any time in future years that will be fixed?
There have been bills introduced in the current Congress, and I wouldn't be surprised to see it happen in the next Congress, but I don't know.
Okay.
Well, my totally off the record would be, I really hope so. All right.
Thank you.
Thank you.
All right. So next we're going to hear about the EHR incentive program in South Dakota, and Angie Brand is here. She is the Stakeholder and Provider Relations Manager for the Division of Medical Services. And poor Angie showed up at work one day and they said, you know what, you should take over the incentive program. And what are you, 2 months ago? Oh, oh gosh, 5 months, you're all time. Poor Angie they dumped all this stuff in her desk and she picked it up and she has turned it around and information is completed, providers are getting paid, and that really has been due in great part to Angie's work and what she's done for the state. So she works within the Division of Social Services in the state, and she develops all the ongoing management of the EHR incentive program. So she'll give you an overview today of what all she's done. So welcome, Angie.
Good afternoon, everybody. Yes, this has been quite the adjustment for me. I still don't know very much when it comes to certain aspects of the program, but I do try to find answers when I am asked. So bear with me as we go forward. If you're waiting on payments or have questions and I'm getting back to you, I will definitely find your answers for you. But thanks for having me today. Go ahead to the first slide. For the incentive payment program, this is a program that's federally funded, but the administrator administrate the funds distribution at the state level. Every state Medicaid is responsible for distributing the incentive payments. And by providing these incentive payments, we do it, this is going to assist the providers with the adoption of the EHRs and the HIEs and improve quality outcomes, improve the access to care, increase the administrative efficiencies, and improve wellness. Next slide. The first step of the attestation that providers can apply for is the adopt, implement, and upgrade. That is the first year. The EHR, then the remaining 5 years would be the meaningful use, that they would have to use their certified EHRs to attest for the meaningful use portion to receive their incentive payments. If the provider is duly eligible, they may actually choose to wait and hold off and receive their meaningful use attestation and incentive payment that way instead of adopting and implementing an upgrade for that first year. Next slide. Where South Dakota is with meaningful use, stage 1, we actually were able to send out that message this week that our portal is accepting meaningful use stage 1 attestations. All the payments that have been made to date have been AIU. It was a great day when I did send that email out to our providers. Lots of documentation had to go to CMS and get approved prior to that privilege being made within our system. So hopefully the providers now will be able to attest, and we do have some user guides out on the website for the meaningful use attestations so they can be completed. But stage 2 guidelines came out in the fall. Holly did an excellent job this morning describing the changes that Medicaid has to make. Those, there are stage 1 patient volume changes that need to take place by 2013. So January 2013. I have written up the requirements. I'll be sending them off to Medicity, who is upgrading our portal for those changes. So you'll see those coming in January or early on 2013. But anyways, if there's any questions regarding those changes, you can give me a call and I will definitely inform you of those. Next slide. This slide just gives you an outline of where our eligible professionals the amounts of dollars they can receive for incentive payments. First, for the providers who meet the 30% Medicaid patient volume, they can get $63,750 over the years, 5 years of attesting. And then the pediatricians, there is a where they can actually attest for 20% of patient volume. If they can't meet the 30, they are allowed to receive incentive by meeting the 20%. And their total would be approximately $42,500 over the 6 years. Thanks. And then for the hospitals, they actually have to fill out a calculation, a worksheet, and within that, those dollars that they put in there, it will calculate out their payment. The program managers prior to myself had written it in that they would receive their payments in three years, and basically the first 2 years at 40%, and then that third year at 20%. But we do have that worksheet available on our website if you are thinking about attesting and want to know what your approximate payment will be. You can look out there and put your numbers in, and it'll give you an idea. And the next slide. This is where we are with South Dakota's payments. As of September 30th, in the United States, there's 47 states who actually attested or have actually paid out payments, and they're at $3.5 billion in the United States. For South Dakota, we are up to 79 providers that have been paid at the $6.1 million. Those are all AIU payments. We have, again, not paid out any meaningful use yet, but those are all just for AIU incentive payments. The next screen is just basically some resources for you. CMS, their website, HealthPoint, they can help you out a lot, so give them a call there. Been great for me to learn off of them, but they are there for you if you need some assistance in this EHR and meaningful use. Then finally, the last website is the final rules for stage 1 and stage 2. This is my contact information, our website. I do plan on making some changes to that website. I want to be able to put up our payments to date so that the providers can see how many payments are going out that we have been able to provide to either the hospitals or the eligible professionals. And also I would like to put some FAQs out there and some the stage 2 changes that I need to have implemented over the next 2 years. And then whatever else, if you guys know something that you want to see on our website, I'm always willing to hear that too. So that's all I have for you. Any questions?
No question. I'm going to read to you the novel of 700 pages. Everybody should be full and hopefully ready to go for the afternoon, so walk across the parking lot. Good for you. We're starting at 1:15, so you have a few minutes to visit the vendors that are over there and network. In the smaller room where Horizon Healthcare was this morning will be Zachariah Syed on hacking the healthcare system, and playing the main stage, if you will, it will be the Medicity presentation. So that's where we'll be, and we'll meet you back over there in a few minutes. I'm getting a flag on the flag. I was 100% wrong as usual. Medicity is in the smaller room, and Zachariah is in the big room. So, okay, great. We'll see you back over there.